So, 6:05, running just a little bit behind. Sorry about that. Welcome back to Haynes Method Hybrid Dry Needling Certification. We have about 4 weeks since our last lecture. Had some things I had to take care of during that time. So, hope everybody enjoyed the time off. Hope you got a chance to get some dry needling in. And did want to remember to remind everyone to continue to work on adding dry needling sessions to your dry needling log, because whenever we get to that final lab session, we're going to need to see that to verify that you've had plenty of opportunity to do some dry needling. With that being said, I don't think there's anything else to cover here. I do want to go ahead and start Lecture 7, Advanced Lumbar and the SI Joint. The things that we'll talk about here, and we've got a lot to cover. So I've got most of this information already on the student portal. If what I don't have, I'll have there in the next day or two. But we'll get that up there super quick. Tonight we'll discuss our supporting evidence. We'll look at our clinical decision making in each of these locations, the lumbosacral muscles, the pelvic rotator cuff muscles, and then the pelvic rotator cuff tendons and ligaments. We'll be looking at three-dimensional anatomy, relevant surface anatomy. In each location, we'll talk about needle placement, and then demonstrate and look at the dry needling technique. The lumbosacral, a lot of this we already covered in the introductory lecture. We'll be adding QL, Iliacus, Psoas Major, and Straightest, Posterior, Inferior. For the pelvic rotator cuff muscles themselves, again, we've already needled a good bit of those, about half of them. Now we're going to add in the deep rotators, the gemellus, obturator, internus, and externus, Quadratus Femoris, and then we'll add Coccygeus and levator ani. We'll touch briefly on some of the pelvic floor musculature as it relates more to back pain and so forth. We'll get more in-depth into the full pelvic floor in our final lecture. In our pelvic rotator cuff tendons and ligaments, we'll look at the Inguinal Ligament, the Interpubic Disc, the Sacrotuberous Ligament, the joined tendons of the Iliocostalis and Longissimus. We'll look at the interosseous sacroiliac ligaments, the Iliolumbar Ligament, posterior sacroiliac ligaments, the sacrospinous, sacral inter and supraspinous ligaments. From a regional and diagnosis protocol, we're going to talk about the thoracolumbar junction and the lumbosacral junction, two very critical areas when dealing with anything in the, especially the lumbar spine. We'll look at sacroiliitis, any of that SI joint inflammation that we deal with. We'll look at the lumbosacral pelvic junction, which is a lot of that back pain that radiates out to the hip, and how we have to treat that as a unit. We'll look and we'll define sciatica, kind of a garbage can term, but it has a meaning. Piriformis syndrome. Again, we'll look at dry needling of the pelvic floor as it relates to the back itself. We'll talk about coccydynia. I'll have a slide that demonstrates that I didn't get a chance to fully update coccydynia. It is a challenging diagnosis, to be sure. So we'll touch on it very briefly. I'll include that in a later lecture as soon as time allows. And then we'll look at peripheral neuropathy. We could have included peripheral neuropathy further distally into the lower extremities, but I felt like this is a nice place to add that in. From a perineural protocol standpoint, we'll look at the cluneal nerves, superior, medial, inferior, and then the lateral cutaneous and the anterior cutaneous iliohypogastric nerves. So, some supporting evidence that I was reviewing. Here's a study by Copenhagen from, where was that? 2015. So it's a little dated. It's not terribly bad. With this study, they were looking to explore associations between demographic, patient history, physical examination variables, and short-term improvement in self-reported disability following dry needling performed in individuals with low back pain. So what they were looking for was, is there some specific key that tells us who's going to be, who will benefit from dry needling? Their volunteers all had mechanical low back pain. At the conclusion, they showed that increased low back pain with the multifidus lift test, what we tend to call more of a bird dog test or exercise, but that multifidus lift test was the strongest predictor of improved disability after dry needling, suggesting that the finding of pain during muscle contraction should be studied in future dry needling studies. I frequently discuss the importance of streamlining and getting more specific with our literature and our research as it pertains to dry needling, and we'll look at another one that demonstrates that as well. But definitely a little key piece there. If your patient does have that multifidus lift test, it could be a strong indicator that they'll benefit from dry needling. Another study by Puntadura from 2017, again a little bit dated, but not too terribly bad. Here they wanted to a randomized controlled trial. The purpose here was the study was to investigate changes in resting and or contraction thickness of the transversus abdominis muscle after dry needling of the lumbar multifidus in asymptomatic patients. So here they're wanting to look and see what changes happen away from the body, away from the site of dry needling, to see what sort of response they can get. They used ultrasound to determine muscle thickness. And what they found was that application of dry needling to the lumbar multifidus was accompanied by decreased resting thickness and an increased contraction thickness of transversus abdominis in asymptomatic patients. So that's good to let us know that even away from the body, that muscle tension can be affected by needling away. We know that the transversus abdominis has a common insertion deep in the lumbar spine, and so it's often speculated that contraction of transversus abdominis is how we initiate contraction of that multifidus in almost a feed-forward type situation. So dry needling can affect, here we see that it can affect muscle function away from the body as well. And that may actually help facilitate activation of that multifidus as a stabilizer prior to moving into whatever the movement is that we're going to do. Another piece here by WHO from 2018. Here they wanted to evaluate the efficacy and the safety of dry needling for treating low back pain. Just a general, does dry needling help? They looked at 16 randomized control trials, and they did meta-analysis of these. And so what they found was compared with acupuncture and sham needling, which was what they wanted to find out. Was dry needling more effective than acupuncture and sham needling for rapid improvement in pain, but more so on subsequent follow-up? How did it look there? And so the dry needling looked to be more effective for alleviating pain and disability at post-intervention with low back pain, but its effectiveness on pain and disability at follow-up was only equal to acupuncture. They recommend that future randomized control trials have more rigorous methodologies being required to confirm their findings. So one of the challenges, again, without standardization of needle placements, needle location, needle depth, and specific terminology of what is actually going to happen in these things, then we run into issues of is this specific, is it non-specific, and what are we trying to accomplish? So I don't feel like our information gets exactly what it needs to. One technical issue here. Thank you. All right. So Now, moving on, we've been talking about our three-dimensional kinetic screen, our motion screen in the upper body, in the spine thus far. The cervical, the thoracic, the lumbar, some general trunk rotation. The one that we did last lecture is going to be the same one that will apply here, since we incorporated some lumbar linear motion and diagonal rotation to assess the thoracic spine. So for excuse me, you'll find at the end of the lecture, your homework is going to be conducting this screen once again, except this time what I'm going to ask you to do is select a patient that you're treating clinically and apply this, and then make some decisions regarding what your findings are. You know, what are you seeing in this screen? Is it relevant? Is it giving you what you're looking for? I'm not going to play the video of the screen again. It will be in the videos available to you, and it's also in the last lecture, lecture 6. So for time's sake, I'm going to skip over that screen and move straight into the muscles in the lumbosacral spine. So here again, we've covered a lot of these, the interspinalis lumborum and the longissimus lumborum, iliocostalis, multifidus, the Psis. What's new here, we'll look at the quadratus lumborum, and we'll talk about it in just a moment in our three-dimensional view. QL is frequently cited as a hopeful location of some lateral pain in the spine and away from midline, and sometimes it is, sometimes it's not, but want to be able to effectively treat that to rule it out as an issue. But we will look at the specifics of QL as well as Iliacus momentarily, and also Psoas. Here there are definitely three important muscles, both in the lumbar region, but especially with these latter two as they travel through the inguinal canal and on their attachment onto the lesser trochanter. So and also serratus posterior, inferior. Again, very superficial muscle, but with its attachment onto the spinous processes and over onto the ribs, they do assist with the inspiration more than anything. There is a nice way to needle through those. Again, if you're going to be needling multifidus or anything in this area, anyway, it's superficial, you're going to be needling through it. But we can show you how to target that specifically. So let's take a look at our first round of three-dimensional anatomy. I will again apologize for the crudeness of some of the recording when I upload this into the recording of the lecture into the student portal. Sound quality will be much improved. It's just technology is what it is. So let's take a look at our lumbar. Our lumbosacral musculature. Let's start superficial and then work our way deep. First, we'll take a look here at our serratus posterior, inferior, and talking about our three-dimensional anatomy, any relevant surface anatomy. So here our origin is going to be spinous process of T11 to L2, an insertion to the external surface of the 9th to 12th ribs, and its action is depress the ribs at their costovertebral joints. Innervation, anterior rami of the 9th to 12th thoracic nerves. These are, and I'm going to zoom in here, going to be fairly superficial strap-like muscles in this area. So as we are dry needling into the multifidus longissimus through here, we know we're going to get through that muscle as we do that. So here we are at 12, so 11, 12, 1, 2. In that area, we will needle through that. If we feel the need to specify these particular muscles, then we can just drop off. And again, it's superficial, 2-3 centimeters at most, anterior to posterior direction, slightly midline. So straightest posterior, inferior. Let's go ahead and hide those on both sides, and then let's take a look at again the longissimus and the Iliocostalis lumborum, and a little bit later we'll talk about the tendons, the epineuroses here of these two tendons as they come down off the ilium onto down. And let me get rid of the sacrotuberous ligament here. Hide that. Okay, so we see that it has a large sacral attachment. So anytime we're dealing with that pain, that may be an area we need to look at. We can definitely find our location with surface anatomy through palpation of the iliac crest coming down to the Psis located here. Again, we've talked about the 3D anatomy of longissimus and the lumbar spine. It is going to sit posterior and superficial to longissimus. So let's pull that away, or superficial to multifidus, I should say. Then iliocostalis will be at that lateral border of the longissimus, and then it's going to travel as far as its terminating or its origin onto the iliac crest, proximal or further away from the Psis. And as you recall, it comes up around the TL junction, then it starts to make a little bit of a lateral course up towards the medial border of the scapula. And then there are more branches of iliocostalis coming even higher. So iliocostalis, one thing to note is with iliocostalis, when we're talking about, I'm going to make a jump here to the quadratus lumborum. So we're looking at a posterior to anterior view. The lateral border of iliocostalis identifies the medial border of quadratus lumborum. So for dry needling's sake, that is a nice way for us to find that lateral border of iliocostalis. That tells us exactly where our our location is of QL. So I'll pull this, my computer catch up, hide that. And so that gives us our location, QL. QL origin is the posterior half of the iliac crest and the Iliolumbar ligament as it's coming from, well, here we are. We'll talk about Iliolumbar ligament in a bit when we get to that. But also its insertion, inferior border of the 12th rib, and then the transverse processes of the 1st to the 4th lumbar vertebra. Its action is extending. Let me get back to that. Okay, it extends and laterally flexes the trunk, and it stabilizes the 12th rib during inspiration. Innervation is through the anterior rami, 12th thoracic, and 1st to 4th lumbar nerves. So fairly decent sized muscle. We will, when we get to the procedure on dry needling it, I'm going to fade it as we look, and then we can see just forward of that, the Psoas Major. So when we needle through the QL, we can take a posterior to anterior angle with our needle, and we can actually needle both muscles simultaneously. We'll end up doing it right about this area right here. Nice line between the ilium and L4 will give us a nice location there. The transverse process, say L4. There we go. So that's our QL, and I'm going to hide our QL. I haven't mentioned multifidus. We've covered it several times. Again, deepest layer of muscle with origin on the sacrum itself, very distal, and going all the way to C2. So let's go ahead and hide that. Let's turn ventrally and look at, again, we talked about Psoas. Its origin, the transverse processes of L1 to L5, and then the vertebral bodies of T12 to L5. It inserts into the lesser trochanter of the femur. So as it drops through posterior to the inguinal ligament, you can see it has its attachment right there. And so given its course, its action is flexing the thigh at the hip joint. One could also be excused for thinking that it provided some external, some rotation at the hip joint. But flexion is its main objective. Innervation, anterior of the first, second, and third lumbar nerves. The iliacus, let me go ahead and remove psoas. I'll hide that. So iliacus, excuse me, its origin is the iliac crest, superior 2/3 of the iliac fossa, the ala of the sacrum, the anterior sacroiliac ligaments. Its insertion is also into the lesser trochanter of the femur via the tendon of the psoas major. Again, its action flexing the thigh at the hip joint. Its innervation, femoral nerve, L2 through L3. We'll find when we get to the needling component, a couple of ways we can needle that itself. Actually, several. We can catch it just lateral to the femoral neurovascular bundle onto the neck of the femur itself. We can also catch it from an anterior to posterior here, above the inguinal ligament, or we can also in a sideline position. See if I can get this guy all the way over. Well, kind of hard. Assuming he's laying on this opposite side, you can push that skin in and needle from a medial to lateral on the medial aspect of the ilium into the iliacus itself. Usually my preferred method is either in this muscle belly right here or just superior into that area. So those are the muscles of the lumbosacral region, 3D anatomy, relevant surface anatomy that we're interested in those muscles, and we'll move on from there. Let's take. Okay, so on to the lumbosacral muscle treatment. Again, we'll look at all of the approaches that we've taken here. Very first thing, the interspinalis lumborum. It's not always a critical piece. I'm going to back up just a little bit here. Let's come back. Not always a critical piece. I guess I'm not going to stop there. For the lumbar. But there are times where you will find that interspinalis, when especially midline spine pain, if there is no other way that you can isolate and rule out other potential pain generators, that is a nice place to go to see if you can flesh out the rest of that pain that you're dealing with. But let's move into the treatment. Interspinalis position is again going to be in the prone position. Needle length here is less than 20 millimeters. We definitely don't want. I'm going to start that over. For the lumbar interspinalis position is again going to be in the prone position. Needle length here is less than 20 millimeters. We definitely don't want to enter that spinal canal. There's no backdrop. We're going to use our fingers to locate the interspinous space between L3 and L4. Then the longissimus and the multifidus, as you recall, in the lumbar spine, we needled those as one single unit. In the lumbar spine, for the longissimus and the multifidus, patient is going to be here in the prone position. Needle length will be 40 to 60 millimeters with a backdrop onto the lumbar lamina. We're going to palpate for the spinous process of L4 at the level of the iliac crest. Needle inclination will be 1 finger breadth lateral from the spinous process and should be a 15 to 20 degree anterior, medial, and caudal angulation in each plane, perpendicular to the skin surface or relative orientation of the vertebra to contact the base of the spinous process on the lamina. All right, now I'm going to pause this momentarily and stop that share. For some reason, I'm having a significant delay, so I'm going to try to restart this and see if that will make a difference for us. All right, let me share that again and see what we can get here. Again, it's going to be in the prone position. Needle length is about 30 millimeters, and there is no backdrop. What we're going to do is grasp the lateral border of the rectus spinae group with a profundus grip. We're going to apply some firm pressure and splay the index and middle finger. Here, we're then going to needle 3 to 4 finger breadths lateral to the spinous process of L4 with a 45 to 80 degree medial. Okay, I'm going to stop that one more time. And wrong side, 43. All right, let me do this. Bear with me. I'm going to just restart that thing. It's like trying to watch a television show and having the sound and the lips not moving together. So let's try this again. All right, let's get down here. All right. There's always some sort of a technical problem. All right. It's thinking about it. All right, I'm gonna redo this one more time. All right, bear with me. In the lumbar spine. Okay. All right, I'm going to try one more time. For the Iliocostalis in the lumbar spine, the patient again is going to be in the prone position. Needle length is about 30 millimeters, and there is no backdrop. Okay, we're just going to do this the old-fashioned way then. All right. We should, and I may be able to get some clarification from my monitor if I'm having some video issues here. All right, I'm just going to play it from here. For the Iliocostalis in the lumbar spine, the patient again is going to be in the prone position. Needle length is about 30 millimeters, and there is no backdrop. What we're going to do is grasp the lateral border of the rectus spinae group with a profundus grip. We're going to apply some firm pressure and splay the index and middle finger. Here, we're then going to needle 3 to 4 finger breadths lateral to the spinous process of L4 with a 45 to 80 degree medial and a 15 to 20 degree caudal angulation in each plane perpendicular to the skin surface or relative orientation of the vertebra. Okay, then and I apologize, my internet signal seems to be a little slow at the moment. Hopefully it'll pick back up. But anyway, we'll move on to the PSIS here. And let's see what we can do with that.
For the PSIS, obviously, patient's going to be in the prone position. Needle length here, 3 to 5 centimeters, depending on patient's habitus. Backdrop, obviously, is the PSIS. We're going to palpate the vertical length of the PSIS, and we're going to use the needle to needle through the connective tissue and peck on the periosteum, locating 2 to 3 different areas on the PSIS.
All right. So from there on to QL. So QL becomes one of these as we get into the advanced work where we start to get a little afraid, little hesitant about needling in this area. The key and the important part is understanding and being aware of your anatomy, your three-dimensional anatomy, where everything is, and know what the safe areas are. What I've put together is definitely areas that this is definitely going to be safe and definitely things that I've needled many times. And so, again, getting over that, being cautious about that is an issue. So here we're going to look at needling both the QL and the Psoas Major, like we talked about on that lateral aspect away from the spine, to affect the dry needle into those with one single needle.
In the prone position, we're going to treat Quadratus lumborum and Psoas Major. Needle length here will be 3 to 5 centimeters. There's not going to be a backdrop. So we're going to palpate for the lateral border of the lumbar iliocostalis in the mid to upper lumbar region. This will approximate the medial border of QL. Follow its path distally to the iliac crest, then 2 finger breadths lateral along the iliac crest and 2 finger breadths superior to identify the needle insertion point. Angulation will be anterior to posterior, and you will needle through the QL before entering the Psoas Major.
So what I'm doing right there is trying to identify that lateral border of the iliocostalis. Like we mentioned, that determines where the medial border of QL is located. Additionally, looking for the iliac crest, that gives us our inferior most margin. And we're going to pause momentarily and see if we can update our internet connection here. So do I need to do anything here? It did. All right. With a little luck, this may improve. Again, that needle location, angulation is just posterior to anterior. And we come back and we look at our landmarks here. We are following that iliac crest over to the lateral border of iliocostalis. We're going to move 2 finger breadths further along that line, along the iliac crest, and then 2 finger breadths superior. Anterior to posterior gives us and here it is a rather lengthy needle to get down into psoas, but a 3 to 5 centimeter needle insertion will give us that depth. A smaller framed person obviously may have to use closer to 3 centimeters. A larger person like myself probably needs a solid 5 centimeters to get to that depth with that structure. From there, let's look at Iliacus. Here, well, let's see how our video is.
So for the iliacus in the sideline position, the needle length is going to be 3 to 5 centimeters here. Backdrop is either going to be none or the internal ilium. Have the patient lay inside lying with a pillow placed in between the iliac crest and the rib cage on the downside, and have the upside arm held in full abduction over the head. We're going to palpate for the superior aspect of the iliac crest at the side-lying apex of the iliac crest. We're going to use a splayed finger technique. We're going to push the skin and the underlying abdominal and oblique musculature medially to hook over the iliac crest. Needle angulation from 1 finger breadth medial to the iliac crest will be cranial to caudal, slightly lateral, directed towards the internal ilium as a backdrop. Caution here, definitely to avoid a medial angulation with the needle and the abdominal contents.
So here it goes without saying, your needle angulation is critical for this needle into the iliacus from the side-lying position. As you can see, I have a towel roll underneath the ilium on the opposite side, and I've got her sky side arm flexed over her head, basically to open up that space between the rib cage and the ilium. There are definitely situations, depending on the patient's girth, where it's just not possible to move enough tissue out of the way to needle the iliacus from this position, which is perfectly fine. There's other ways to get to it. But depending on the situation, sometimes this is the more appropriate way to go. All right, I'm going to stop my share there one more time and see if I can solve my problem. Not exactly sure what is creating my issue here. But I'm going to return and see if that will improve at all. All right, let's come back to the share. Okay. So from there, move on to the straightest posterior inferior. Again, that small, thin strap-like muscle we see from T11 down to L2.
For the serratus posterior inferior, patient again is going to be in the prone position. Needle length is going to be 2 to 3 centimeters, and there's no backdrop here. We're going to palpate and identify the spinous processes of T11 to L2, most easily identified by following the 12th rib towards the spine. We're going to needle from lateral to medial, slightly caudal, 2 finger breadths lateral from the spinous process. It is going to be superficial, and there is no backdrop unless including underlying musculature.
Again, nice and superficial in that area. We will definitely see that we have, if we're dealing with something else, we're in that lumbar area, that lumbar TL junction especially, that odds are we're going to needle through that. But again, if we need to isolate that, that is a nice technique to isolate straightest posterior inferior. Okay, so again, let me apologize. I'm not certain if it's my internet. I'm solid wired here. It could be that everybody decided to Zoom today, and we're just having a bandwidth problem across the platform. What I put online on the student portal will be cleaned up, and we'll have access to good, clean content. So that being said, pelvic rotator cuff muscles. Again, we've dealt with quite a few of these already. Gluteus Maximus, medius, minimus. Those three forming that large hand, smaller hand, then the fist location of those muscles. We talked about a nice central location right here that encompasses max, med, and min. And depending on how far down we get, we may even get a little piriformis in there as well. Anyway, a nice little hot spot right there for dry needling. We have the TFL coming up. This lateral piece attaching to iliotibial tract as it dives further down towards the tibia for the IT band, and then the piriformis. We've done these already. Piriformis. Hopefully, you're getting a good bit of some opportunity to implement this posterior hip dry needling into your practice with your patients. But then into the deep rotators. So the deep rotators, obviously they're extremely small, and it would be foolhardy unless we were to pull out an ultrasound unit to give us ultrasound guided needling into these structures to actually identify them. I don't feel like that's necessary. There are times with obturator internus and externus where we will needle it more at its attachment onto the pelvis itself as opposed to lateral. But for these rotators, our technique will be dropping a single needle into the top muscle, superior gemellus, and then we will redirect that needle all the way down, landing in Quadratus Femoris. And as you see, they follow a nice, distinct line. Obturator internus is basically just a small tendon at this point, so we may be hitting it, we may not. This one probably more appropriately addressed dealing from the internal aspect right here. We move into the inferior gemellus, again, just a little bit below the obturator internus. Below that, then on the opposite side, we'll look at it in a 3D anatomy in a moment. We'll have obturator externus. That is a little bit more beefy. It sits just anterior to Quadratus Femoris, which is our final of the rotators. So it sits anterior to here, to Quadratus Femoris. And so again, we'll take that redirect approach to needle all of those, at least peck into them. Obviously, Quadratus Femoris is the largest of the rotators, so that's definitely one that we'll let that needle land in. If we're going to apply some stem for a longer period of time, we'll drop that in there and let it cook right there. So we move further, and now we want to look at coccygeus. We'll talk about that a little bit more in detail, 3D anatomy, but the coccygeus has an origin, origin on the sacrospinous ligament, also the ischial spine. So the sacrospinous ligament, we'll see in a moment, just basically sits right on top of the coccygeus. But its insertion is the lateral margin of the coccyx and the related border of the sacrum, so that that junction between the coccyx and the sacrum is what we're interested in. You'll find we use our sacral horns as a location to find our landmark. We'll run a test needle down onto the lateral border of the sacrum to find out what our depth is. Then we're going to give ourselves about 1 up to 1.5 more centimeters of depth as we move off of that lateral border of the sacrum to land into coccygeus. And then finally, levator ani, or the three pieces of levator that we're interested here is the Iliococcygeus. So here, 3D anatomy will show it a little bit better. You can see coccygeus itself sitting right here. The Iliococcygeus attaches just at the distal end of coccygeus, and then it encompasses the remainder of the coccyx, or down onto the tailbone. So similar, we'll use an approach where we drop needle down onto the sacrum. Here we're going to drop needle down onto the coccyx itself. That's our test needle. That tells us how far of a depth we have. We'll move a finger breadth lateral from that and then drop again 1 up to 1.5 centimeters into Iliococcygeus. A lot of times the pelvic floor coccygeus and Iliococcygeus is overlooked when dealing with patients with low back pain, but so often this posterior triangle of the pelvic floor is involved with issues related to the spine. So we do want to include those when necessary. And so let's see how our 3D anatomy is going to pan out here.
Okay, let's get into the three-dimensional anatomy, relevant surface anatomy of the pelvic rotator cuff. I include the pelvic rotator cuff in the advanced lumbar spine SI joint simply because of the proximity to the lumbar spine. A lot of the pain complaints that we do have a little further distally and then lateral, some of that radiating pain complaint that we get. As you know, we do see some back pain that is just limited to central spine, slightly adjacent. But just as frequently, we see radiation into the SI joint region or laterally, inferiorly down towards the greater trochanter. We may even see some radiating down the lateral aspect, posterior, anterior, into the leg. And that's why I do include these structures here. So we'll start with, again, relevant surface anatomy. Definitely want to be able to identify the iliac crest all the way posterior to the Psis. Laterally, we want to be able to identify the superior aspect of the greater trochanter, and then using surface anatomy, iliac crest, to come across to identify L4. We can drop down to locate L5, and then subsequently the end onto the sacrum. We can use those landmarks to identify. But I will say we also want to be able to identify with this course, this lecture, the tip of the sacrum, the tip of the coccyx, and the lateral border of the sacrum. As we get to certain structures, we're definitely going to need to know and be able to identify those areas. So onto the Gluteus Maximus. We've covered glute max and the first of these muscles quite a bit through the introductory piece, but let's cover quickly the glute max origin, the area of the ilium located posterior to its posterior gluteal line, the posterior aspect of the sacrum and the coccyx, and the sacrotuberous ligament. It's been removed here normally. Okay, there it is. The sacrotuberous, I was thinking sacrospinous, but sacrotuberous ligament there. It inserts the tubercle of the iliotibial tract on the tibia via the iliotibial tract, and then the gluteal tuberosity on the femur. Its action extends, laterally rotates, and abducts the thigh at the hip joint, innervated by inferior gluteal nerve L5 to S2. So that one is, let's hide that. That'll bring us to let's do TFL and the IT band first. Get it out of the way. So TFL, the muscle, attaches to the iliotibial band. IT band is it's running distally to its tibial insertion on the tibia, but its origin, the anterior superior iliac spine and the anterior 1/3 of the outer lip of the iliac crest. So it is easy to find if there is some sort of a lateral tension dysfunction going on at the greater trochanter. You will be able to palpate that band of tissue coming up. That'll be the posterior border of the iliotibial tract, with TFL sitting slightly anterior. It inserts, again, the tubercle of the iliotibial tract on the tibia via the iliotibial tract. Its action is assisting in medial rotation, abduction, and flexion of the thigh at the hip joint, with its innervation to superior gluteal nerve L4, L5S1. And so let's get that removed so that we can then look at glute med and then glute min. So glute med, now let me undo that. All right, get out of that. So with your 3D application that you should be using, it does take a little finesse in learning how all the intricacies of the system work. But anyway, glute med Bring that back up here. Origin, the area of the ilium located between the anterior and posterior gluteal lines. And inserts into the lateral aspect of the greater trochanter of the femur. It's always curious to note the glutamine inserts more on the posterior aspect of that greater trochanter, while as glutamine we see attaches more anterior. So its action medially rotating and abducting the thigh at the hip joint. This one is innervated by the superior gluteal nerve L5S1. We'll hide it, get us down to glutamine. And when we're finished, I'll demonstrate something on the glutes. So glutamine, bring that back up, please. Thank you. Origin, the area of the ilium located between the anterior and inferior gluteal lines. Inserts into the anterolateral aspect of the greater trochanter of the femur. Again, sits more anterior. Its action is it immediately rotates and abducts the thigh at the hip joint. Its innervation is superior gluteal nerve L5S1. So in dry needling, any of this lateral hip joint, when we get to it, you'll see that there are several needle placements that we do for this problem. One of them you're going to find for Gluteus Maximus, we're going to find we're going to take a line from the greater troch to the Psis, and at a midpoint, we're going to drop a needle right there. Well, that happens to be the convergence of both the Gluteus Maximus, Gluteus Medius, and Gluteus Minimus, and that tends to be a hot spot, a very tender location. We get a lot of good benefit from the needle placement right in this area. But let's go ahead and move medius out. Let's look at minimus. Now let's look at piriformis. Its origin is the pelvic surface of the sacrum and the sacrotuberous ligament. And so this is the sacrotuberous ligament coming from the ischium all the way to the sacrum and then further up to the Psis. And so it does have an attachment there. Its insertion in the superior border of the greater trochanter of the femur. And so you can tell it sits more medial on that lip of the greater trochanter. And so its action is it laterally rotates and transversely abducts the thigh at the hip joint. And it's innervated by the nerves of piriformis, S1, S2. So there'll be two needle locations here. One are traditional that we have already gone through in the first lab, needling out here. As we get now more advanced state, we'll see a method where we can dry needle off into the muscle belly itself a little bit right here. Have to be cautious here because of the area of travel of the sciatic nerve as it's coming right here. And so we'll learn to adjust our depth for needling to simply needle into the piriformis. All right, I'll hide that. And then the next muscle in the chain of the rotators. First is superior gemellus. Its origin is on the ischial spine. So we have the spine right here that creates the foramen above and below the sciatic foramen. And so its origin, ischial spine, insertion in the medial aspect of the greater trochanter of the femur. It will sit just inferior to where piriformis was. Its action is laterally rotating and transversely abducting the thigh at the hip joint. Its innervation is nerve to obturator internus L5 to S2. So I'm just going to fade that and we'll drop down to obturator externus. Obturator internus. Here the origin is the internal surface of the obturator membrane and the adjacent bones. For our purposes here, how we needle all these rotators will be limited to this area right here. When we get to the advanced pelvic floor, we will discuss how to needle into the muscle belly itself right here. But it's, again, origin, internal surface of the obturator membrane and the adjacent bones. It inserts into the medial aspect of the greater trochanter of the femur. So as you can tell, we're just making our way down this line on the femur. Its action laterally rotates and transversely abducts the thigh at the hip joint. Its innervation again is the nerve to the obturator internus 5-1. So we'll fade there, and then we'll drop to the inferior gemellus. Here we are going to look at let's see, origin, again, so directly comes on the ischial tuberosity. We'll see that for that and for Quadratus Femoris. It inserts the medial, medial aspect, the greater trochanter of the femur. It's actually, again, laterally rotating, transversely abducting the thigh to hip joint, nerve to Quadratus Femoris 5-1. So we're gonna skip one of the muscles here and drop. Let me put that back and just fade it. So we'll get to now Quadratus Femoris. We'll do this first. Quadratus Femoris, origin, the lateral margin of the ischial tuberosity. It is inserting into the quadrate tubercle of the femur. Its action is laterally rotating the thigh at the hip joint, and it's innervated by the nerve to Quadratus Femoris, or L5S1. So fairly broad muscle. When we needle, that will be our terminal needle placement or location as we redirect. I'm going to hide that so that we can now see obturator externus. So internus sat right here on the obturator foramen. For obturator externus, it's going to sit on the anterior aspect. So here, and I'm going to come back to our posterior view here. So here our origin is the external surface of the obturator membrane and the adjacent bones. It inserts in the trochanteric fossa of the femur. Again, a lot of attachment right here. Its action laterally rotating the thigh at the hip joint, and it's innervated by posterior branch of the obturator nerve L3, L4. So those are the rotators of the hip, the external small rotators. Again, we're going to needle those specifically for this area with one needle with a redirection approach. We will move on to, let me reorient here, and I'm going to take some of these ligaments out. So we'll get rid of the sacrotuberous, sacrospinous is already gone. All right, so actually let me get rid of that as well. All right, so the next one we'll look at will be, come on. All right, coccygeus. Here its origin is the ischial spine. I get origin insertion backward. So the ischial spine will be its origin right here. Again, that's that ligament, sacrospinous ligament, gives us our border for creating the ischial, sciatic foramen. But the coccygeus attaches or has an origin here, and its insertion is into the internal aspects of the sacrum and the coccyx. So it has attachment on both of the locations here. So as we move through this, we'll look at the levator ani in a moment. We see the tip of the coccyx, we have levator ani or Iliococcygeus. Then we move up half of the coccyx into the lower half of the sacrum, and there we have the coccygeus. And then that superior piece, then we have the piriformis, all in a nice line down the sacrum to the tip of the coccyx. Coccygeal action provides structural support to the adjacent pelvic structures. Its innervation is anterior rami of the fourth and fifth sacral nerves. More specifically, it assists in pulling the coccyx forward to help control during defecation. So we'll move from there, and then we'll identify the Iliococcygeus, or one of the pieces of the levator ani. Its origin, the ischial spine, again right here. Then there's a tendinous arch of the levator ani. We have a hard time seeing it there. There it is. So it also across this tendinous arch right there. And then its insertion will be into the coccyx and the iliococcygeal raphe and the anococcygeal ligament. Our biggest area where we're concerned is in the coccyx, because we can needle into that. We'll demonstrate how to provide a proper depth so we get our good response with that tissue. And those are the muscles. So similar, its function action is pulling the coccyx forward, assisting in defecation. And it plays a key role in control of the pelvic floor as far as pain, incontinence, and so forth. So those are the muscles of the pelvic rotator cuff.
Okay, so for treatment, I am not positive that my internet situation is a whole lot better, but I'm going to give it one last shot. So let's I've got a strange little error here. I'm going to copy this. I'll save that for a little bit later. So let's see what happens. Okay. So as far as treatment, let's come in. We'll start with, so because of time, we've already been through gluteus maximus, medius, minimus.
For the gluteus maximus, the patient is going to be in the prone position.
Pause
Needle
this
length here
guy.
will be
TFL, we do want to jump down to piriformis. Again, all of these needle placements are available in the portal, and we should have already covered this and had a lab on these. So let's get down. TFL.
For the tensor fascia.
There it is. All right. So piriformis.
For the piriformis, the patient again will be in the prone position. Needle length can be 30 to 50 millimeters. The backdrop here will be the ischial ligament. For the lateral attachment, we'll palpate for the superior aspect of the greater trochanter and locate its medial most aspect. Needle insertion point is 2 finger breadths medial and 1 finger breadth superior, posterior to anterior, using the ischial ligament as a backdrop.
Okay, and I'm going to back up because I didn't demonstrate that in that video, but there's an important piece that we need to see. If I can get there rapidly. Come on.
For the
Okay, so I'm going to have to include that as an
the patient
addendum
again
here.
will be in the prone position.
I'm going to bring it all the way down to the very end. So there's also a way that we tend to find a little, probably more common than not. So here we are out on the greater trochanter. When we went through our lab drawing our our surface anatomy, we identified that the piriformis itself came over here. We drew our helper's line that broke from the Psis down to the sacral horn, and we broke that into 3. And we identified where piriformis was going to come across there. I'm going to pause that again because I'd like to finish what I'm saying. We're there. Let me come back. And hopefully it'll stay paused. Okay, so anyway, similar to how we addressed dry needling onto the sacrum for Iliococcygeus, or we discussed it, needling onto the sacrum, onto the coccyx, and then using that as our test. Very similar for piriformis. We're going to find that lateral border where we've identified where the piriformis will be. We're going to needle down onto the sacrum there at the lateral border. All right, it's just going to roll for a second. Let me move forward a little bit here. Let it do its thing. And then I'll pause it. Okay, there's a lot of the rotators. I will get back to piriformis momentarily. And now I'm going to pause. So again, back on piriformis, what we look at is finding that lateral border of the sacrum. We're going to needle down onto the sacrum, onto that lateral border. That gives us our depth. We identify on our needle how deep we're dropping that needle. We're going to move 1 finger breadth lateral from that onto the piriformis itself, the medial aspect of the piriformis. Then we'll drop that needle down another centimeter and a half, so that we get the bulk, the muscle belly of that piriformis. If you're not getting a response in the lateral aspect, then we'll do it there on the medial. All right, so we've moved from there, and I'll include that update in what I post online. So back to the deep hip rotators. We've already looked at the verbiage. Now let's just kind of walk through this as a whole unit.
For the superior gemellus, the obturator internus, inferior gemellus, obturator externus, and quadratus femoris. We're going to treat this as a single unit.
Okay, so we're just discussing it here. We'll look at the actual needle placement momentarily. Coccygeus, again, we're going to find the horns, 1 finger breadth lateral from that after we've identified our needle depth with our test.
For the coccygeus, the patient position will be prone. Knee length here will be 2 up to 3 centimeters, and there will be no backdrop. Precautions here for the 5th sacral nerve, the coccygeal plexus, the nerve to the levator ani muscle, and the rectum. For the procedure, we're going to palpate the lateral border of the sacrum, and then the distal aspect and the sacral cornu, or the sacral horns. We're going to insert a needle posterior to anterior, slightly lateral, to where you just palpated the sacral horn to determine needle depth at the sacrococcygeal junction.
This is your test needle.
Then we'll move 1 finger breadth laterally until you feel the drop off of the lateral sacral border, and we'll needle in a posterior to anterior angulation, slightly lateral, no further than 1 to 1.5 centimeters deeper than your test needle, to treat the coccygeus and avoid the deeper rectal contents.
Again, coccygeus, as you remember, half of it is on the sacrum, half of it is on the coccyx. So right at that junction, we can drop off after our test needle and ensure that we're right in the middle of that muscle. Okay, very similar approach for Iliococcygeus.
For the levator ani, specifically the Iliococcygeus, position is going to be prone. The needle length here will be 2 to 3 centimeters, and there is no backdrop. Precautions here: the 5th sacral nerve, the coccygeal plexus, and then the nerve to levator ani muscle and the rectum. For the procedure, we'll palpate for the lateral border of the sacrum, and then the distal aspect and the sacral cornu, or the sacral horns, and the distal aspect of the coccyx. The Iliococcygeus attaches to the distal half of the coccyx. We'll insert a needle posterior to anterior, slightly lateral, to where you palpated the coccyx, to determine the needle length at this needle depth at this location. Then we'll move 1 finger breadth lateral and needle in a posterior to anterior angulation, slightly lateral, no further than 1 to 1.5 centimeters deeper than your test needle, to treat the Iliococcygeus and avoid the deeper rectal contents.
Coccygeus and Iliococcygeus, any of the pelvic floor musculature, you definitely have a frank conversation with your patient about what you're going to palpate for, where you're going to put your needle, and make sure that you have good consent and good understanding from your patient on needling that. That being said, frequently these can provide a lot of improvement with pain in that lower posterior triangle, deep low back issue, and the pelvic floor itself. All right, so moving into the tendons and the ligaments of the pelvic rotator cuff. There are quite a few here. Any of them can be involved with things that we find that we're having issues with. Occasionally, even the inguinal ligament, I've included that because it will be involved with some other structures. Let's jump right into these. And let's see if we can't just go ahead and move on to interpubic disc. It doesn't happen very often, but I actually had a patient symptomatic for interpubic disc dysfunction yesterday. And actually, that was this morning, actually. And so definitely a structure with potential problems. Needling can provide some good relief there. Let's move on. So sacrotuberous ligament, see, it's a rather large ligament from Psis over to the sacrum and then down to ischial tuberosity. 3 potential locations of problem. We want to be able to needle all 3 of those. And then this aponeurosis, this merging of the tendons of Iliocostalis and longissimus, very frequently have some issues there. So a nice little technique to be able to get deep into both of those structures. The interosseous sacroiliac ligaments for our SI joint problems, both this one and the one deep to it. This approach, superior, inferior, superior, needle directed into that sacroiliac joint can provide some pretty good relief for those problems. The Iliolumbar ligament will demonstrate how to identify that. Again, there is that deeper posterior sacroiliac ligament and the sacrospinous ligament if we're dealing with, and obviously because it sits superficial or more posterior to coccygeus, we will needle that as we needle into coccygeus. We use the same approach. How often are the sacral interspinous and supraspinous ligaments relevant? Not that often, but again, anytime midline issues are developing deep in the sacrum, definitely want to be able to needle those for improvement.
Okay, let's look at the ligaments that we deal with the lumbosacral spine. We have we have interspinous ligaments in the lumbar spine that we can needle. We don't typically attribute those to much pathology, and because they are midline, really kind of hard to needle into them. However, if we are, and we've talked about the interspinalis that we can needle. We can needle those. There they do sit in between each of the spinous processes. I don't really include that as part of the system. However, we will needle into them if we do needle into interspinalis. So worth mentioning there. Let's talk and let's start with. Let's see, where should we start? Let's start on the anterior aspect. I do include this because there is some component here. We'll probably deal with this more with the hip, but we do have a piece that we deal with on the inguinal ligament. We do have muscles attached there, and there's some nerve issues that we'll deal with, but it is, let's see here. From the ASIS over to the near the pubis itself. Let's see. We also have here the interpubic disc. Get rid of that. Sitting in between. A lot of people do tend to have pain at the interpubic disc for a variety of reasons, and definitely it is a needleable connective tissue. So in the anterior aspect, that's pretty well what we'll look at. We'll move more posteriorly, and let's hit first the The Iliolumbar ligament, frequently see people with pain in this vicinity. The Iliolumbar ligament itself is fairly large. The area that we can gain access to on the posterior aspect between this transverse process of L5 and L4, and where it comes over and attaches onto the anterior surface of the ilium there, we can gain access to that. So that is one to consider. On the posterior aspect, the sacrotuberous ligament. There are places along this ligament where we can definitely do some needling. Typically, we'll do it at the Psis. We'll do it more near the sacrum, or we can do it near the ischial tuberosity. It could be done anywhere along that line, but those three attachment points, probably the location where we'd have more of our issue. On the left side of the pelvis here, we see the sacrotuberous ligament has been removed. Beneath that, we will find the interosseous sacroiliac ligament. As we can see, it does a fairly good job of providing a little bit more support here for the ilium over to the sacrum, so that connective piece that we see for the SI joint. I will remove that, and then we'll get a little bit deeper into the posterior sacroiliac ligament. And as you can tell, it covers, let me come forward. It's going to sit deep there. So in this sacroiliac region, probably a really strong, on the posterior side, support mechanism for that. So we had the other ligament structure, then we have this. So a lot of ligamentous support right there. We do take advantage of that. We do needle into ligamentous structure. So if we are having some issues in that SI joint, we will find that we want to needle inferiorly, and now in this case laterally, to get into all of this ligamentous structure there. I'm going to go ahead and hide that one so we can get deep into that SI joint, and that's kind of our target, is right there. We move, let's come on down a little bit. So here we have the sacrospinous ligament, sits just posterior or more superficial to the coccygeus muscle, which was just anterior to this. So that if we're going to needle into the sacrospinous ligament, we'll be needling into the coccygeus as well. We also have in this area the supraspinous ligament, again, just a continuation of the ligaments running between the spinous process, or the superficial part of the spinous process. How often is that clinically relevant? Probably not very often, but worth having in your tool belt in case. Deep to that is going to be the interspinous ligaments. Those will actually travel out a little bit laterally from that. To provide a little bit of some support there. And let's see, I think that is all of the ligamentous structures here. I do want to bring up, we've got all of those, I want to bring up one more grouping of ligaments here. Let's see, let's do it right here. And that is the tendons of the iliocostalis and the longissimus. So as we get low down into the lumbar spine, we do tend to find people having a lot of pain in this area. And as you can tell, this muscle has started to converge from true contractile element to more a tendinous grouping, and very frequently these muscles here, as you can tell, that's also the location of the thoracolumbar fascia. So all of these tissues are starting to plane together and merge, and truly these are merging in this area, so it's hard to differentiate one versus the other. So like to treat those almost as a single unit. A lot of times we can needle directly into that, onto the sacrum in this area. So good piece to know on that. And those are our tendons and ligaments of the lumbosacral spine. Okay, let's look at the ligaments that we. Okay, let's look at the.
Oh, goodness. I'm trying to back up here. Okay, so we'll start with our treatment of the ligaments, and we'll start running through these.
For the inguinal ligament, position here is going to be supine with a needle length of 1.5 centimeters, and there is no backdrop. The precautions here, the anterior cutaneous branch of the iliohypogastric nerve, the lateral femoral cutaneous nerve, the ilioinguinal nerve, superficial circumflex artery and vein, and then, given the location, any of the lower abdominal contents. So the procedure, we're going to palpate the ASIS and then the origin of the sartorius as the subject lifts the leg off the table. Needle location is going to be 1 finger breadth medial from the sartorius along the line of the inguinal ligament. So with its attachment, we'll needle for inguinal ligament right in this area. Slide back to me. Oh. And relax. So for the interpubic disc, definitely a little bit different approach, male versus female. For the male, you may have to have the male assist in moving himself out of the way, so it's a little bit easier to access that structure. And let's come on down. For the interpubic disc at the pubic symphysis, the patient will be in the supine position. This will be a shallow needle stick. It will be 1.5 centimeters, and there is no backdrop. For the procedure, we're going to palpate for the space between the pubic bones, and we're going to move caudally 1 finger breadth to identify the needle location. The angulation here will be anterior to posterior with a slight caudal angulation with no backdrop. And again, with males especially, the location of the round ligament, the nerve bundle running through there, palpation, try to keep that midline as much as possible just to decrease any excessive extraneous discomfort that your patient might feel. And then on the back for the sacrotuberous ligament. So we'll needle both at the PSIS. We'll drop down to the sacrococcygeal junction. We'll actually find the horns between. We'll look at the inferior horns to get a little bit lateral. And then on the medial aspect of the ischial tuberosity, very near where the hamstrings attach. So those 3 different needle locations. For the sacrotuberous ligament, we'll have 3 needling locations of this broad reaching ligament. First at the PSIS, the needle length here is going to be 3 to 4 centimeters with a backdrop down to the lateral sacral border, precaution of the medial cluneal nerve. For the procedure, we're going to palpate for the PSIS and the sacral horns and the sacrococcygeal junction. We're going to draw a line connecting those two, and we'll bisect the line in half. And then needle placement will be midline in the cranial half and a P to A angulation with a backdrop of the sacrum. At the sacrococcygeal junction, here needle length will be 2 centimeters, and there's going to be either no backdrop or very similar to the sacrospinous ligament. Precautions here for the medial cluneal nerves. The procedure, We'll palpate for the sacral horns at the sacrococcygeal junction. Needle placement is going to be 1 finger breadth lateral from that sacral horn in a posterior to anterior angulation with no backdrop, or the sacrospinous ligament. It's a very superficial structure with the rectum anteriorly. And then thirdly, the ischial tuberosity. The needle length here is 3 to 4 centimeters again. Backdrop is the medial surface of the ischium. Precautions for the posterior femoral cutaneous nerve, the inferior rectal artery and vein. We're going to palpate for the inferior-most aspect of the ischial tuberosity. Sacrotuberous ligament attaches to the medial aspect of the ischium. So needle placement will be at the medial border of the ischium, posterior to anterior with a slight lateral angulation with a backdrop onto the ischium.
So again, we'll locate the Psis and we'll needle the Psis, the superior-most aspect of the sacrotuberous ligament first. Then we'll drop and catch the piece there at the sacrococcygeal junction. And then lastly, we'll move into that attachment on the medial surface of the ischial tuberosity. So again, I do get very specific on finger widths and our palpation for a very specific reason, so that we can be absolutely certain of the location where our needle is going to land, that it is landing, number one, safely, but two, where it needs to be clinically effective. So here, the tendons of the Iliocostalis and longissimus.
For the tendons of the Iliocostalis and the longissimus, their attachment is onto the dorsal and the posterolateral surface of the sacrum, the iliac crest. Position for treatment is going to be prone. Needle length will be approximately 3 centimeters. Backdrop here is either none or the sacrum for the longissimus. Precautions for the medial and the superior cluneal nerves. For our treatment procedure, we're going to palpate for the Psis. For the iliocostalis tendon, we'll insert the needle 2 finger breadths cranial. For the longissimus tendon, we'll insert the needle at the midpoint between the Psis and the S2 spinous process. Needle angulation will be posterior to anterior with no backdrop, or the sacrum for the longissimus.
So the first was for iliocostalis, and then this is for the tendon of longissimus. Okay, to the interosseous sacroiliac ligaments. This approach is your bread and butter go-to treatment for SI joint dysfunction. That's purely limited to that. We tend to not include any muscle when we're purely dealing with an SI joint dysfunction, again, because there's no muscle crossing that junction.
For the interosseous sacroiliac ligaments, the procedure here, we're going to palpate and identify the spinous processes of L5 and S2 at the level of the Psis. Needle placement will be at the midpoint between the spinous processes and the ilium with a 45-degree angulation medial to lateral with a backdrop at the SI joint. A cranial needle will be angled slightly inferior, and the caudal needle will be angled slightly superior. Unilateral rotation with tenting is recommended with both needles.
So you want to identify L5, drop down to Psis. We know Across from that is S2. Superior angle is going to be directed inferiorly at about 45 degrees lateral, and the inferior needle will be angled superiorly, again, about 45 degrees lateral, so that we land into that sacroiliac joint junction. Okay, we'll jump up to the Iliolumbar ligament. And let me move forward here.
For the Iliolumbar ligament, we're going to address that from the posterior aspect. Continue to rotate here. And so for the procedure, we're going to palpate for the interspinous space between L4 and L5 and for the iliac crest. We're going to draw a line between the interspinous space closer to the inferior border of the L4 spinous space, laterally to the iliac crest. Needle placement will be at the intersection of the helper line and the iliac crest in a P to A angulation with no backdrop.
Again, also probably a nice location for some unidirectional rotation with some tenting. Okay, now we'll also address the posterior sacroiliac ligaments. This is a structure that we will have needled if we were dealing with SI joint dysfunction, as we needled into the previous ligament that's been faded there. But this is a different approach to get it a little bit more in depth.
Posterior sacroiliac ligaments, we will look at a procedure that will involve palpating for the PSIS. There'll be 3 needle locations at the PSIS. One finger, and it's P to A, 1 finger breadth caudal from the PSIS, also P to A, and then 1 finger breadth cranial and medial, which will be PA slightly lateral angulation.
Again, being a fairly large ligament, take 3 needles to catch all of that structure. Ideally dealing with SI, which we'll show, dealing with SI joint problem, we have then also place our other 2 needles in that same area with that lateral direction. Again, sacrospinous ligament, very similar to how we will needle the coccygeus, because it just sits superficial to that structure.
For the sacrospinous ligament, the position will be prone. The needle length is going to be 1.5 up to 3 centimeters. The backdrop will be none, and the precautions here is the nerve to levator ani and the rectum. The procedure, we're going to palpate for the sacral horn at the sacrococcygeal junction. We're going to move 1 finger breadth lateral to the sacral horn, which will be the needle placement with a posterior to anterior angulation with a depth no greater than 2 centimeters.
Then lastly, the sacral interspinous and then the sacral supraspinous ligament.
For the sacral interspinous ligaments, we will take a little closer look here. The position here will be in the prone position. Needle length is going to be 1.5 up to 3 centimeters in depth with a backdrop down to the sacrum. We're going to palpate for the sacral spinous processes. And needle placement will be about a half of a finger breadth lateral to the spinous process, and we're going to needle with an angulation posterior to anterior with the sacrum as the backdrop.
Sacral interspinous ligaments. Yeah, just about 1/2 finger breadth away from midline there. And then the sacral supraspinous ligament.
For the sacral supraspinous ligament, zoom in on that structure right there. Here, position, the patient will be in the prone position. Needle length is 1.5 to 3 centimeters. Backdrop directly down to the sacrum. And the procedure here will palpate for the spinous process. Needle placement will be between the spinous process and a posterior to anterior angulation with the sacrum as a backdrop.
And just a complete midline P to A down to the sacrum. Okay, now let's move on to the regional protocols. I will go ahead and apologize. This is going to run long. On a side note, and so I've taken lots of courses in dry needling over the years and getting certified and so forth. And frequently what happens is if time is running long, then instructors tend to just skip certain things. And so you miss out on some things. So one of the reasons I like this format is it's available. You get all of the instruction that you need, but you may have to go back and review a little bit of it. So anyway, at the TL junction, just a little research here, 15 to 25% of pain in patients with pain in the posterior iliac crest area results from injury of the posterior ramus of the T12 thoracic nerve. And it's often confused with back pain originating in the sacral region. So the TL junction, very critical in dealing with any of the lumbar spine. As you recall, our lamina is much more narrow there. It's much more potentially unstable region because of its size and how it's structured. So for the TL junction, we have 3 locations. We're going to layer these in what we'll treat first, what we'll treat second, what we'll treat third. Again, we went through the protocol for how often to do primary, when to move on to secondary, when to move on to tertiary, and the same approach still applies here. So our primary location for treating the TL junction is going to be the multifidus, longissimus, and iliocostalis up around this at the TL junction. Our secondary location is going to be the latissimus and the lower traps. Again, they all converge in that area. And then tertiary, we'll look at the transverse abdominis, the internal, external obliques, the serratus posterior, inferior, and then quadratus lumborum and psoas major. So in this case, I've shown psoas, the QL big needle here. When we get to the lab, I'll demonstrate how to needle it in the side-lying position as well to get to psoas, just a different location, just as effective in that one spot. So these are going to move. When I put this on the student portal, you will be able to slow those particular pictures down. In this case, it was not possible. So for the TL junction, let me move on to, let's see. So for our primary location, I've got all of the pictures there. Okay, so primary location, we'll just get a start
prone position. Our primary locations will be multifidus, longissimus thoracis, and iliocostalis thoracis. These can all be accomplished by 2 separate needle placements at each spinal segment, at each segmental level. and which segmental level is just determined on patient symptomology. We move to our secondary locations, and here we'll look at latissimus and the lower trapezius. So coming more to that TL junction right there of the lower traps, and latissimus, big broad muscles that contribute to that TL junction. And then finally moving down to our tertiary locations, and I will move to our location here. All right, so as we move, I'm going to look at two different sides. Our obliques, internal and external obliques, and then transversus abdominis, definitely contributors to issues related to TL junction. And then further, and I've gone a little bit deeper here, we'll look at Quadratus lumborum and the Psoas Major. One could say Iliacus may treat them similarly, but those are the structures identified, and we would look at treating for pain in the TL junction. Okay, so the regional protocol for the TL or the thoracolumbar junction. Here, the dry needling protocol, patient is going to be in the prone position. And this is going to be any of those pain patterns that you see from middle to lower thoracic spine all the way down to, let's say, the level of the iliac crest. So very frequently, and when we do treat quote unquote back pain, we are going to be dealing with more of a TL junction, especially if it comes up into that lumbar spine towards the thoracic junction. Here, our primary dry needle locations are going to be the multifidus, the longissimus, and iliocostalis. Our secondary locations, we're going to go ahead and get latissimus and the lower trapezius. And then for our tertiary locations, we'll hit transversus abdominis, internal, external obliques, the serratus, posterior, superior, QL, and Psoas Major. So let me move this out of the way. Let's bring up our fella here. All right, so first thing we're going to look at, our primary locations will be multifidus. Let me bring up my pen. 3D black. So multifidus. Let's say we wanted to catch what we know here is L4, 3, 2, 1. Let's say we wanted to needle. Let's zoom in a little bit here. So again, we know 5, 4, 3, 2, 1. The base terminal end of the trapezius. Let's catch our tool again. So 3D. Again, we want to catch multifidus, so we'll come up. Let's come up a segment above. So 1 finger breadth lateral. Okay, we'll do above, and let me change that to black. That's much easier to see. Okay, we are 3D there. Wonderful. So there's multifidus at T12. We'll drop down a level and catch T1. We can take that, or L1, and we can take that all the way down segmentally as we need to. For our longissimus and thoracic, longissimus will be needling as it sits right here. We'll needle through that in the lumbar spine. As we get into the thoracic, it's going to veer a little bit lateral, so we'll have to make a different approach. But here, we should be getting into that. For our iliocostalis, then we're going to have to come from this lateral position, and here our needle will be oriented from lateral to medial, fairly superficial, so we don't get too deep, but still catch all of the fibers of the iliocostalis here. So that's our primary locations. Our secondary locations, let me clear our business there, is going to be the latissimus and the lower trapezius, lower traps. We will just simply catch those. Let me get my pen. The lower traps we can catch right here. We'll just grab those with a pincher grip, lumbrical grip possibly, and then thread across this direction. And then for, that's lower trap for latissimus, we're just going to put our hand into that bulk of the muscle in the axilla, and in about this location we will needle away from midline from medial to lateral, making sure that we don't get into that rib cage. So let's clear that. We'll get to our tertiary location, and here, different locations to do the transversus abdominis, the obliques. So on those, we can actually, one of the easiest ways to get those is with your patient in the side lying position. We can use a pincer grip, and pulling out my pen again, we can pinch those muscle fibers together, and then in the side lying position again, we can needle. It's hard to see this in a three-dimensional view, three-dimensional and a two-dimensional view, but we'll needle through that. We'll thread through that tissue from a posterior to anterior, or if we have to be on the anterior side, anterior to posterior, just making sure that it's in a tangent to the body as well. We don't want to orient that needle into the visceral compartment. And so there we can catch transversus abdominis, internal, external obliques. So we move from there. We want to look at the fibers of the straightest posterior inferior. And again, we can see the border of that muscle group right here. So anywhere in this vicinity, we can needle. Fairly superficial, probably less than between 2 and 3 centimeters as far as the depth there. And then lastly, we can go after, let me clear, let me clear those. So lastly, we can come after QL and Psoas. So one of the easier ways, let me hide there. I want you to show you the QL. So here is QL. So you can see the orientation of the fibers of QL. If we take this lateralmost border of Iliocostalis and move further onto the iliac crest, in that window is where we can definitely have our best impact on QL. Now, if I hide that a little bit deeper, then we can see the fibers of Psoas. So the way to have a good needle placement here is at the lateral piece of Iliocostalis, just a finger breadth or so further lateral, we'll needle posterior to anterior with some decent depth to make sure that we penetrate into Psoas Major. It can also be done from the side lying position, but I like and I prefer to take QL and Psoas right here, posterior to anterior. And that would comprise our needling protocol for the thoracolumbar junction.
Okay, I'm going to move forward to the lumbosacral junction. For time's sake, we are 7:53. We've got a lot of content. To sum this up, the L5S1, incredibly important, very similar to the junction at the TL. It's particularly vulnerable to misalignment, primarily because of the angle of the sacrum in its relation to L5. So let's move down. I'm going to just go through this and get straight to the video. You can see there's a lot of structures to deal with at the lumbosacral junction. I'm going to start this and then move past the anatomy discussion, which we have already done, and move to
the
actual needle piece.
The dry needling.
Okay, that must be my next slide.
And the dry needling protocol for the lumbosacral junction. Initially, patient will be in the prone position, and we'll look at our primary
pardon me a bit. I don't think we got to any drawing. Try that again.
And the dry needling protocol for the lumbosacral junction. Initially, patient will be in the prone position, And we'll look at our primary dry needling locations. Here we'll have the multifidus, the Iliocostalis lumborum, the longissimus lumborum, the Psis, and the sacroiliac joint. For our secondary locations, look a little bit deeper. I don't have this exposed right here, but we'll look at the Quadratus lumborum and the Psoas Major. And then finally down to our tertiary locations. Let me come back out just a little bit here. We'll look at the dry needling for the Gluteus Maximus, medius, and piriformis. Minimus is a little bit further lateral, but it could be included as well.
So as we move through these different areas, you're going to find that a lot of your same key muscles are represented in each of the levels. So obviously, we frequently are going to needle multifidus, longissimus, anything in the lumbar area. Those are always going to be included. Frequently, if it's moving a little bit lateral, we're going to be bringing in some of the gluteals as well. And you're going to see quite a bit of overlap in a lot of these approaches. Sacroiliitis, just inflammation of the sacroiliac joint. I'm not looking to see if there is an up flare, an out flare, any misalignment, anything like that. I'm just curious about the inflammation itself and what we can do to needle down into that to make a change there. Our primary locations, again, for here, again, multifidus, longissimus, iliocostalis. Why? Because they all terminate in this location right here. Same area we're feeling our pain problems. So we go ahead and needle those. Our secondary locations, the interosseous sacroiliac ligament, the posterior sacroiliac ligament, and these are these locations right here. So I've duplicated one right here. So for the interosseous sacroiliac ligament, those are the two. Where'd my mouse go? There it is. That will do at an angle, one superior to inferior, one inferior to superior to land deep in that SI joint. And then for the posterior sacroiliac ligament, again, we'll have these three locations here to get the bulk of this bigger, more superficial ligament itself. And then tertiary, finally, if we have to, we can get the Iliolumbar ligament, the sacral interspinous ligaments, and then the sacral supraspinous ligament.
The dry needling protocol for sacroiliitis, our primary dry needling locations will be up in the lumbar spine. There we'll look at multifidus in the longissimus and iliocostalis lumborum. Our secondary locations will drop a little further distally. Here we will dry needle into the interosseous sacroiliac ligament and the posterior sacroiliac ligament. So some of these much deeper structures here. And then finally, third, the Iliolumbar ligament, the sacral interspinous ligaments, and the sacro supraspinous ligaments.
Again, I've said this and I'll say it again. It always stands to reason that if we're having inflammation, we also need to be doing some manual therapy as well. Dry needling is a great way to deal with inflammation, but we still have to address the mechanical imbalance, whatever is creating that inflammation in the first place. Sacroiliac dysfunction there. Okay, what I call the LSP or the lumbosacral-pelvic junction, and there I'm referring India that centralized low back pain radiates down, say, towards the SI joint to PSIS, but then you see it radiating laterally towards the to the greater trochanter, any of that posterior hip business. It's probably more common than a lot of the things that we do see. So let me jump and play. All right.
The protocol for the lumbosacral pelvic junction, the LSP junction, Very similar to the lumbosacral junction, a few more needle locations to encompass a little bit more of the pelvic girdle itself. The primary needle locations will be that lumbosacral junction protocol. So all those needle points from that initial protocol. Secondarily, we'll look at adding on to this the protocol for sacroiliitis, so a little bit more in depth into the sacroiliac joint. And then finally, for the tertiary locations, the entire pelvic rotator cuff dry needling location, which will include Glutamine, max, min, as well as TFL, piriformis, and then all of the rotators down to Quadratus Femoris.
So it's nice when we have an isolated case of specific pain at one single level, especially if it's an older patient, someone with more degenerative processes on board. We are going to start seeing more of this lateralization of those symptoms. So again, your evaluation, your palpation, identify your structures that are inflamed becomes critical. So again, in this case, we start with our primary structures, hit the things that really should be creating the bulk of our problems. If it doesn't address itself after a visit or two, then you move, throw in the SI joint and all of the structures in there. And then lastly, if that's not resolved, then go ahead and come on out and hit the pelvic rotator cuff. And then sciatica. So sciatica has a couple of different meanings. It's what I like to call a garbage can term, that it doesn't really mean a whole lot to most people, but it can mean a couple of different things. One, it can be any of that lateralization, that radiating pain that goes down into the hip, down the backside or the side of the leg, following the path of the sciatic nerve. And by definition, it can be have an impingement either at the spine itself where the nerves exit and come out to form the sciatic nerve, or it can happen at the level of piriformis and superior gemellus, where the sciatic nerve runs in between those two. And any tightness, excessive tightness, entrapment could happen there. For that reason, I'm going to refer to sciatica as the second piece that has more to do with combination of piriformis and that superior gemellus below it.
And for the dry needling protocol for, in quotes, sciatica, our primary locations will be the pelvic rotator cuff. Again, here we're looking at the three gluteal muscles, TFL, piriformis, and then the deep rotators. Our secondary needling locations, here we will include both medial and lateral aspect of piriformis, and then finally, we'll come back and include everything in the sacroiliac joint itself, that sacroiliitis dry needling protocol itself.
Okay, and part of that is piriformis syndrome, which it's described as being a rare neuromuscular disorder. I think it's probably more common than we think. It's just usually in conjunction with other things as well. There are rare cases where it is simply piriformis, but usually it's conjunction with other things. In this case, we'll address it as the piriformis. Again, you'll see what we're going to do. We're going to needle the lateral piriformis, the medial. We're going to go ahead and catch TFL, glute-med, glute-min. We're going to catch, and we haven't gotten to this yet, greater trochanteric bursitis, the sciatic bursa of Gluteus Maximus, both really good areas to needle, but we'll get those when we get to the hip. And then we've already included the pelvic rotator cuff, the rotators further distally.
Dry needling for the piriformis syndrome, our primary locations will be the lateral and the medial aspect of piriformis, two different dry needling locations. We'll look secondarily at the pelvic rotator cuff itself. So here we'll look at glute max, mean, min, TFL, and the deep rotators of the hip down to Quadratus Femoris. And then finally, for our tertiary locations, we will include dry needling for the greater trochanteric bursitis protocol, which on that lateral aspect, and then the sciatic bursa of Gluteus Maximus right on the ischial tuberosity.
So when we get to the hip, that bursa, the bursitis we get off the ischial tuberosity, can be a very powerful tool. Obviously, very close to sciatic nerve. Want to be very careful and very specific in needle location, needle placement, and needle angulation. I actually have mine that needs to be needled from time to time, and I can vouch that it's a good treatment approach. All right, onto the pelvic floor. Again, we're just going to talk about the two muscles of the pelvic floor here. We're not dealing specifically with pelvic floor dysfunction, but as it pertains to problems with related to the low back pain, frequently we do see that pain, that inflammation extend further into that region as well. So here, our primary location is going to be coccygeus. Our secondary will be Iliococcygeus, and then lastly, we'll cover piriformis, either laterally or medially off the border of the sacrum. So all three of those can elicit a change in that pelvic floor.
For the pelvic floor protocol, this is a protocol geared more towards lumbopelvic pain, not specifically to the pelvic floor as it relates to pelvic pain, incontinence, things of that nature. So here we'll address three primary structures, muscles. One is the coccygeus, coming off of the sacrococcygeal junction. Our second will be the Iliococcygeus, which will be, we'll identify that off the tip of the coccyx itself. And then lastly, we'll come up a little bit more proximally and look at piriformis. Again, just a much more distal treatment approach for lumbo-pelvic pain. For the pelvic floor as a whole, we'll look at it entirely a different protocol for that approach.
Okay, so coccydynia, pain problems that extend. Let me go back go back. I'm going to present this and update that at a different lecture, not tonight. Got busy and didn't get a chance to update it as much as I would like. So we do frequently see patients with coccydynia, and there are some common areas that we've already talked about that we'll needle with that, but there are probably a couple more that we want to throw on top of that as well when dealing with that. Lastly, in peripheral neuropathy, we'll address peripheral neuropathy a little bit more in detail when we get into our final lab session. But basically with this, there are a lot of the nerve structures coming out that have the potential to be entrapped somewhere along their path. We've identified their most common area of entrapment, and we've simply used our needles to try to two things. One, see if we can use some needle manipulation to have an impact on that entrapment itself, loosen that connective tissue. But two, see if we can stimulate that nerve transmission, that nerve impulse heading back to the central nervous system to improve the quality of the nerve function. There are situations, diabetic neuropathy, past a certain point, probably not a whole lot that we can elicit some change. However, I have seen, so probably more beneficial for our idiopathic neuropathy patients, but a lot of the patients we see with neuropathy can also see some improvement in function that they currently are dealing with. And if there is an entrapment and we can release that entrapment, then we have every reason to believe that we should improve the function of their sensation, their motor control, and so forth. I don't have any research on it just yet, but I do see improvement anecdotally with the patients that we use the dry needling protocol for peripheral neuropathy on. So briefly, I'll cover this again. We'll cover it more in lab. Move down. So our locations first is going to be the common fibular, superficial fibular, and deep fibular nerve. Secondary, we're going to get, and that's not the ones. Let me go back. Let's see if I get it a little bit later here. All right, so our secondary locations, tibial and sural, obviously those aren't they. But finally, our tertiary, our lateral femoral cutaneous, our posterior femoral cutaneous. I'm going to go back one more time. Our saphenous nerve and then the obturator nerve. More often than not, we'll find that we get the bulk of our improvement in our lower limb, perineal, sural, and saphenous on the tibia itself. So we can elicit some really nice changes just in those areas.
The dry needling protocol for peripheral neuropathy will basically use our superficial and deep sensory nerves as a target for trying to decrease symptoms related to peripheral neuropathy. Hopefully stimulate the nerve function. So our primary locations distally in the lower limb would be the common fibular nerve, the superficial fibular nerve deep here, and then the superficial fibular nerve as well here on this lateral aspect. We'll move to our secondary structures. Here we'll go further posterior to the tibial nerve and the sural nerve, and then finally we'll come more proximal into, let me come up here, there we are, into the lateral femoral cutaneous nerve, the femoral nerve itself, the saphenous nerve, and the obturator nerve.
Okay, then the specific perineural protocols themselves, superior and the medial cluneal nerves, they're very close to each other, so they basically get treated as the same treatment protocol. But basically, with the cluneal nerves, especially the superior and medial, let me see if I can get to, okay, so superior cluneal nerves are this area, the nerves are highlighted in pink, and they do have the potential as they come out over the iliac crest through the thoracolumbar fascia, they can find themselves entrapped there. And so we will end up doing some needling in that location. So as you can see, we've got sacral horns, we've got Psis, and then following a line up to the iliac crest, to the apex of the ilium right here. And we're going to bisect that line, and we're going to needle into that. We can go into the thoracolumbar fascia itself, but we can also come down over the iliac crest and try to elicit a change there. So probably more related to improving tissue extensibility in the thoracolumbar fascia above or more superior to the crest, and then try to improve nerve function more below that. A lot of times we will see people with tenderness along the iliac crest right there, and very likely could be superior cluneal nerves. The medial cluneal nerves will come out of underneath this thoracolumbar fascia below the Psis, and so we may drop down again, sacral horn, PSIS, cut that in half, or into thirds, I should say, and we can needle into that area as well. Similar, superior for improving the entrapment, and inferior to improve nerve function. And I'm going to jump through a lot of this to get down to the video discussing and describing. Okay, so here's for superior gluteal.
The dry needling protocol for the superior cluneal nerve. It arises from the posterior rami of the first, second, and third lumbar spinal nerves. They innervate the skin of the superior and lateral parts of the buttocks. The superior cluneal nerve is occasionally prone to entrapment, where they pass through the fascia near the posterior iliac crest, which can cause unilateral low back pain. For the protocol itself, our primary neural location would be for the superior cluneal nerve from the PSIS to 4 finger breadths along the ilium. The length there would be 1.5 centimeters. For our secondary muscular locations, Gluteus Maximus, the longissimus, and multifidus with a needle length of 3 to 5 centimeters. For our tertiary locations would be the gluteals laterally to the greater trochanter. And then finally, our proximal spinal segmental locations would be L1, L2, and L3.
And then for medial cluneal nerves.
The dry needling protocol for the medial cluneal nerves. The medial cluneal nerves arises from the posterior rami of the first, second, and third sacral spinal nerves. They innervate the skin of the posterior part of the buttocks. This branch may become restricted in its osteofibrous tunnel against the iliac crest, just as osteofibrous tunnels affect other nerves, such as in carpal tunnel syndrome. The clinical symptoms include pain at the low back, which may radiate to the ipsilateral leg. The clinical signs include marked tenderness at the iliac crest rim just above the dimple at the buttock, and decreased touch sensation of the buttock just below the iliac crest. For the protocol itself, our primary locations would be the medial cluneal nerve, the middle 1/3 along a helper's line from the PSIS and the sacral horn, and then also the superior cluneal nerves from the PSIS to 4 finger breadths along the ilium. Needle length here would be 1.5 centimeters. Our secondary muscular locations would be Gluteus Maximus, the longissimus, and the multifidus. Needle length would be 3 to 5 centimeters. Our tertiary locations would be the gluteals laterally to the greater trochanter. And then finally, our proximal spinal segmental locations would be S1, S2, and S3.
Okay, now in inferior cluneal nerve, and we'll just jump straight to the video here.
The dry needling protocol for the inferior cluneal nerves. The inferior cluneal nerve arises from the posterior femoral cutaneous nerve and supplies the posterior thigh as well as the distal buttocks. Its segmental location is S2 and S3. The inferior cluneal nerves, also called the gluteal branches of the posterior femoral cutaneous nerve, innervates the skin of the lower part of the buttocks. They arise as branches, the posterior cutaneous nerve of the thigh. Our primary neural location will be the junction of the medial and lateral hamstrings at the inferior aspect of the gluteus maximus. Also at the inferior medial aspect of the gluteus medius. Needle length here is 1.5 to 3 centimeters. And then our proximal spinal segmental location will be at S2 and S3.
So we mentioned the cluneal nerves as you palpate, do a palpation assessment of your patient. You find all of these areas that are giving you problems and just not seeming to respond to problems related to what you would think would be a normal posterior hip lumbosacral pelvic issue, where you're needling glute med, you're needling glute max. If you're not seeing the results, you may need to consider the role that the cluneals have to play in, in creating some of that sensation change, some of that pain that they're feeling right there. So might look at that as a secondary approach to dealing with that from a neural standpoint. The lateral cutaneous iliohypogastric nerve, there's a potential site of entrapment in the abdominals themselves, and then as that nerve courses across the iliac crest again, any of the nerves that cross there can seem to give us some potential challenges. So let's move to our locations. All right.
The protocol for the lateral cutaneous iliohypogastric nerve. The nerve supplies the skin of the gluteal region. The lateral cutaneous branch or the iliac branch pierces the internal and external oblique muscles immediately above the iliac crest and is distributed to the skin of the gluteal region behind the lateral cutaneous branch of the subcostal nerve. The size of this branch bears an inverse proportion to that of the lateral cutaneous branch of the subcostal nerve. When harvesting bone from the anterior iliac crest, the lateral cutaneous branch of the iliohypogastric nerve is most likely to be injured. For the dry needling protocol, patient will be in the sideline or possibly prone position. Target structure, again, lateral cutaneous iliohypogastric nerve. Our primary location is going to be along the iliac crest from the location of the posterior IT band attachment, posteriorly 2 to 3 finger breadths further posterior. The length here will be 1.5 up to 3 centimeters. Our secondary muscular locations, again, internal, external obliques, the transversus abdominis, and tensor fascia lata. Needle length there would be 3 centimeters. Finally, our proximal spinal segmental locations would be L1.
And the anterior cutaneous iliohypogastric nerve. So curiously, as we get into a pelvic floor, we'll look at incontinence. And interestingly, the anterior cutaneous iliohypogastric nerve is a nerve that we can use for dry needling for a incontinence protocol. In this case, we're talking more about a sensory issue. And let's go ahead and move on to our approach.
The anterior cutaneous iliohypogastric nerve. The anterior cutaneous branch of the iliohypogastric nerve passes along the crest of the ilium and it enters the internal oblique muscle at the level of the anterior superior spine of the ilium and runs through the aponeurosis of the external oblique muscle. These branches supply the abdominal area beneath the navel, and its branch is L1. The anterior cutaneous branch, or the hypogastric branch, continues onward between the abdominal internal oblique and the transverse muscles. It then pierces the internal oblique, becomes cutaneous by perforating the aponeurosis of the external oblique about 2.5 centimeters above the subcutaneous inguinal ring and is distributed to the skin of the hypogastric region. For the dry needling protocol, the patient will be in the supine or the sideline position, and again, our target structure is the anterior cutaneous iliohypogastric nerve. Our primary dry needling location along the iliac crest from the location of the anterior IT band attachment anteriorly 2 to 3 finger breadths further anterior. Here, needle length will be 1.5 to 3 centimeters. Our secondary muscular locations will be the internal and external oblique, the transversus abdominis. Needle length here will be 3 centimeters. And finally, our proximal spinal segmental location will be L1.
Okay, so we struggled through my technology issues. Again, I don't know if it was an internet problem on my side, if Zoom was just overloaded with meetings or what. I will make an effort to make sure that what I put on the student portal is, number one, you can hear it. Number two, you can see it. So I may get a chance to include the coccydynia at that point, but I may just wait so that I can present that to you in lecture. As we move through these things, I will start putting together. So everybody paying attention here should have already been through lab number 1 and using the slides that I created that you can use on your phone or on your laptop, on your iPad to find the specific needle locations and so forth. I will start putting these together in that format as well so that you can have those. So I will distribute those in some form as we move forward. Now that we've been through all of the spine, I may just lump all of the spine together and then come back and then lump all of the extremities together. We'll see what that looks like. So post-lecture assignment, lecture number 7. Again, you've seen this before, very similar. One difference here. One, we're going to select an active patient that you're treating. And I want you to perform the 3D kinetic screen on that patient. So that is the cervical linear motion times 5 reps, the cervical diagonal rotation times 5 reps on each side, the trunk rotation times 5 reps, and then the lumbar linear motion, 5 reps, and the lumbar diagonal rotation, 5 reps each side. You can submit a video if you want to. I'd be glad to see it. Only do it if you have permission from your patient as defined by your practice. Every practice is different. I'm not party to seeing anybody's personal health information or video if you haven't obtained video release approved by your facility from the patient. So submit if you can. If you don't, that's fine. Then I want you to submit a brief description of what your analysis is of that 3D kinetic screen. After that, given the limitations that you found, give me an idea of what you think the structures would be that you could target for dry needling. Once you identify that, go ahead and treat them. After you've treated them, then I want you to come back and same treatment. I want you to repeat the 3D kinetic screen and see if the things that you identified and that you treated have now changed what's happening with that screen. More than likely it will. And if it does not, then that odds are it tells you that there's another structure that's more relevant to that functional, that physical limitation that you're seeing. So after doing that, describe any change that you noted with that. That is all for this evening. Our next lecture, lecture 8, we're going to move away from the spine now. And now we're going to start with the shoulder, move through the upper extremity. Then we'll move down into the lower extremity. But 2 weeks from now, advanced shoulder. If you have any questions, problems, issues along the way, feel free to yell at me. Realize that I'm muted. Feel free to yell at me. If there's anything I can answer along the way, I will gladly do that. And I will get a proofed up recording of this lecture on the portal as soon as possible. Any questions, let me know. Have a good week, and we'll see you in 2.